This is Kim Newlove, host of the Pharmacist Voice podcast. Thank you for joining me for episode 107. If you're new to the show, welcome. I alternate solo shows and interview shows. The solo shows are about my career change from pharmacist to voice actor. I have been an Ohio licensed pharmacist for 20 years, but I'm no longer in clinical practice. Instead, I provide voiceover and narration services. My specialties include medical narration, e-learning, explainer videos, and audiobook narration. If you have a project in mind or you want to listen to my medical narration demo, you can find both through my website, thepharmacistvoice.com. My podcast interview shows feature a variety of people who use their voices to advocate for something, educate in some way, or entertain. Today's episode is an interview with Matt Grissinger, Director of Error Reporting Programs at ISMP, the Institute for Safe Medication Practices. Matt earned his Bachelor of Science degree in pharmacy from Philadelphia College of Pharmacy and Science and is a fellow of the Institute for Safe Medication Practices as well as the American Society of Consultant Pharmacists. Matt first joined ISMP in the year 2000 as an ISMP Safe Medication Management Fellow. His current responsibilities include working with healthcare practitioners and institutions to provide education about medication errors and their prevention, and reviewing medication errors that have been voluntarily submitted by practitioners to ISMP's National Medication Errors Reporting Programs, MERP. I invite you to read Matt's full bio. There's a link in the show notes. He has held numerous leadership positions and has contributed to a number of publications. In addition, he's an adjunct assistant professor for Temple University School of Pharmacy. The Institute for Safe Medication Practices, or ISMP, is the nation's first 501c3 nonprofit organization devoted entirely to preventing medication errors. ISMP is known and respected for its medication safety information. For more than 25 years, it has also served as a vital force for progress. ISMP's advocacy work alone has resulted in numerous necessary changes in clinical practice, public policy, and drug labeling and packaging. Among its many initiatives, ISMP runs the only National Voluntary Practitioner Medication Error Reporting Program, publishes newsletters with real-time error information read and trusted throughout the global healthcare community, and offers a wide range of unique educational programs, tools, and guidelines. In the year 2020, ISMP formally affiliated with ECRI to create one of the largest healthcare quality and safety entities in the world. And ECRI and the ISMP PSO is a federally certified patient safety organization by the U.S. Department of Health and Human Services. As an independent watchdog organization, ISMP receives no advertising revenue and depends entirely on charitable donations, educational grants, newsletter subscriptions, and volunteer efforts to pursue its life-saving work. Visit ismp.org or follow ISMP1 on Twitter to learn more. Without further ado, here's my conversation with Matt Grissinger. Hi, Matt. Welcome to the Pharmacist Voice podcast. How are you?
Hi, Kim. I'm doing well. How are you today?
Doing well. Matt, I invited you to come on the podcast today to share how ISMP uses its voice.
And yeah, we use our voice in a lot of ways, Kim. I think one thing I have to make sure the audience understands while we are pharmacists and we're on a pharmacy podcast, we are the voice of the medication use process, if that makes sense, right? So yes, I'm a pharmacist. I've been in ISMP for 20 years, but we look at and address issues with the processes with use of medications. Those processes include prescribers. Those processes include nurses and pharmacy technicians. So Our voice to me is not just pharmacy, although we promote pharmacy's voice in medication safety. I want to make sure the audience understands that we're talking about when we talk about medication use, it's everybody involved in anything to do with medications as well. So, we can use that voice in many ways. And honestly, Kim, it really starts with you and all the people listening to this podcast, because we don't know about things unless pharmacists and other practitioners speak up and tell us about issues too, right? So a lot of information that we get or start with comes from people like Kim, who come to ISMP's website and report unsafe conditions, things that make you uncomfortable, errors that have happened, but also the investigations. And we share that information in many ways to pharmacies and healthcare practitioners around the world so they learn about why things are going wrong and then also provide strategies to prevent harm to patients down the road.
I think what you do is very important. And back when I went to pharmacy school from 96 to '01, I'm not sure that ISMP was really in the picture. Can you talk a little bit about maybe from that time frame till now, what's changed? How did this all get started? How old is ISMP?
ICP it was started by a pharmacist by the name of Mike Cohen. Mike Cohen is still president today, worked at the Temple University Hospital in North Philadelphia, also went to the Temple School of Pharmacy. And he was co-editor or assistant editor of a journal called Hospital Pharmacy. In March of 1975, he wrote his first column about medication errors. And what that column was little stories of what went wrong and strategies. And those stories came from the Temple Hospital. And in fact, Kim, the first story I still tell today, still happens today. There was a doctor who wrote an order for insulin, and he wrote for you for the dose. The nurse misread it as 40 units and gave a tenfold overdose. And what's part of it, Kim, is sad is this is written in 1975, and we saw that problem today in 2021. So Mike started, so that was the start of our reporting program to get information from people to share back out to people. And so it was a true grassroots program. He had this reporting going for many years. Then eventually in 1994, he incorporated ISMP as a nonprofit organization. And so since then, I personally joined in 2000. So Kim, when I joined ISMP, I was maybe the 10th employee at ISMP. So for me, it's just as crazy for me too, Kim, because I've lived through, since you graduated college, the whole progression of ISMP as well. And really, it's just, I think the newsletter helps. We have many newsletter publications that we share the information you share with us. The flagship is an acute care version that's been out since 1996. It's come out every 2 weeks since 1996. So picture the variety of stories and concerns and errors we've had in that time period. So that probably started things, but we're also involved in a lot of activities, whether it's giving a lot of presentations, Kim. For example, the ASHP Midyear meeting, that's in December, right? So we often have presentations there, symposiums there, webinars, get the word out that way. But also we do a lot of in-person work, which means an organization could contract us to come visit your hospital or outpatient pharmacy and do a consult. And this is a proactive risk assessment where we kind of look at your medication use process to see what could possibly be not good and wrong. And I tell you, Kim, we can go to hospital for like a full week and walk around every unit. So it's not pharmacy, it's ICUs, emergency departments, operating rooms, pharmacy, formulary committee meetings, P&T meetings. So I think over the time between our outreach through publications, we have stuff in trade journals, educational programs. I just think over time, Kim, that has built up. And also it's helped that we've been recognized by associations who will cite us to say, well, hey, ISMP says this, ISMP says that. I think all that piles up. Over time, it's almost like a snowball. Like have it start with a small snowball, we keep rolling it, and eventually gets to be a bigger snowman. It's kind of like that progression over time.
You just named a lot of different settings. Wow. And it's a good thing that you're able to intervene and improve processes and solve problems for them. A lot of different medication errors can happen in a lot of different settings, which makes it hard for you probably to answer this next question. How then does ISMP define a medication error?
So we'll use the definition that was developed by the NCCMERP. That's the National Coordinating Council of Medication Error Reporting and Prevention. And Kim, they have some really long definition I don't have memorized. But essentially, I mean, think about it. It's anything that goes wrong with the use of medication while it's in the possession of somebody. But again, think of all the processes involved in medication use, from buying it, prescribing it, transcribing it, order verification, order entry, production, labeling, dispensing, delivery, storage on a unit, nurse administration, patient education, any breakdowns in all those processes. So it's pretty broad. What happens, Kim, especially when you talk with outpatient people and pharmacists, their viewpoint's different, right? They're in the outpatient setting, they think wrong drug errors, wrong patient errors. And that's predominantly what they deal with. Go to the acute care side, it's way different because you have all these other disciplines and departments, right? So now you have infusion pumps and wrong rates and issues with patients not getting weighed in hospitals. So you have errors with dosing because of not weighing patients. So it's just different. Defining medication error is easy. Knowing where they happen and how they happen is like a whole nother level beyond that.
Yeah, good point. Just revealing how they happen and that they exist makes them preventable, because when you can find those common threads and you can figure out what's happening over and over again, then you can change things. You can put processes in place to improve things. So, who should report medication errors to ISMP?
Yeah, we'll take error reports from anybody, any practitioner. I think the key thing what the audience to understand though is, our reporting program is a qualitative medication error reporting program, not a quantitative error reporting program. And it sounds like a minor difference, but if you're working in an outpatient setting or in a hospital setting, their reporting programs are almost about the quantity. How many did we get in? And let's look for trends and stuff like that. That's not how we approach things. Remember how I described how Mike Cohen started the ISMP and reporting program? It was, hey, Kim, tell us about the problems and concerns you have. You tell us the story and the reasons why it happened. We share that with other people. So our reporting program is more about the whole story. So I don't just want your error reports. I want the error reports and your investigations and conclusions, because you have to understand, we don't have all the answers. We learn from you. Well, maybe the reason it happened in your place is unique. And we also rely on getting strategies from you too. So at times we don't have all the answers, but as frontline pharmacists and other practitioners that say, hey, we put this system change in place to prevent future errors from happening, we can now share that with everyone else. So just want to stress, so it's really important. We don't want error reports. We want error reports with the story and the investigations that's shareable. So when we tell stories in presentations and publications, Kim, those stories are easily remembered, right? People don't remember bar graphs, but they remember that story I told you about someone who died from a fentanyl patch. So that's kind of our approach to reporting and sharing information.
You brought up a really good point. Stories are powerful. Personal stories are powerful. In fact, I think my first experience knowing who ISMP is through the State Board of Pharmacy from Ohio includes ISMP's stories in their
Yep.
newsletter quarterly. So I've had exposure. I've been a pharmacist for 20 years now, and I start seeing these stories and I read them and I think, wow, it really takes me there. Like that could happen to me if
Right,
I were in
right.
that situation. And just being aware of that, I think helps prevent me from doing that.
Yeah, I agree 100%. And you made a good point. Again, you remember stories, and it's amazing the stories I remember from years here at ISMP. But listen, and I shouldn't say the longer the story, but the more detailed the story, the more facts in it, the better the story, right? It's not like, well, hey, Kim gave out the wrong drug. Okay, well, that wasn't a story, that was a sentence. Well, tell me the whole chain of events. What was the day like? What led to that issue? What contributed to that problem? And so on. Just makes for a nice, fuller story. It's memorable, But you also get a lot of learnings from that, right? You learn the reasons why it happened. You learn the things that could stop it from happening again. So that's all part of that story.
Well, I've got to ask you, since we're talking about stories, what's a memorable story that you can recall?
Uh, so one I can remember, this probably goes back 15 years, and it started with our work about fentanyl patches because while fentanyl patches have a very important place in pain management for opioid tolerant patients only, uh, we as pharmacists do a poor job educating patients on medication use. So years ago, a woman called ISMP because she was on fentanyl patches for some reason. And one day she walked into the bathroom and found her child dead in the bathroom. That's because the child, she had just disposed the patches in the trash can. And like kids who see band aids, right, and stickers, put the patch on
Yes.
themselves.
Oh,
And she found the kid dead from that. So stories like that, Kim, and there's lots of those which are preventable. A lot of them are preventable events. And that's why I think hopefully people understand today that the pharmacist's role in preventing errors is more than just stopping wrong drug errors leaving the pharmacy. What about the patient's home? Like, how are we teaching patients about how to properly store things and get rid of things and put them in the right spots and how to take them, right, and preventing errors at home? That's up to the pharmacist listening to this podcast today.
wow, that story is impactful. But you do bring up a good point also with poisoning prevention. That is kind of an unintentional poisoning. So you end up with a child that could have
Right.
been saved because if the parents would have just known to fold the corners and, connect those so that, make a little taco, squeeze it together, and
Yeah, right.
it's already, sealed up, and hopefully the child can't unpeel it and get into it anymore, or just to flush it. That is a
Yep.
great counseling opportunity. But also, as pharmacists, we are community leaders. We are
Yeah.
safe people to talk to in the community. We can go into schools. We can talk to fifth graders about preventing their, younger siblings or cousins that they might be looking after from that sort of fate as well. Thank you for bringing that up. That is a horrible outcome, but
Yeah. And Kim, one
great
thing that,
story.
and I think it's tough because when we learn about medications, you know, that's why sometimes in schools I get concerned because we have kids memorize these facts about drugs. This is how you dose it. Here's what it's indicated for. But then they teach that, fentanyl patches really have 4 days of drug in a 3-day supply. So the kid ends up dying because, yeah, the patch was done, but there's still a whole day of fentanyl in that patch. Like those little nuances help us as pharmacists really explain and understand what could go wrong. And listen, we don't have all the answers of what could go wrong either. I think the people listening today may know some little tidbits too that we got to share with people too, that crazy things happen with medication use. They're never intentional, right? And so how can we all learn from these mistakes?
Great points. Well made. Well, the ISMP has a great website. So I'm changing the topic just a little bit here. There are many things that we can all learn as healthcare professionals from ISMP. We talked about webinars already. You talk at conferences. We talked about newsletters and state board journals.
Mhm.
And I want to go to the website because there is so much information there. And as a pharmacist from yesteryear that graduated before ISMP really grew in its influence, I kind of want to talk about what tools and resources should pharmacists, pharmacy students, and other healthcare professionals be accessing on the ISMP website.
Yeah, Kim. So we have a lot of good tools and resources on the website. I want to start with probably the best thing to start with is our self assessments. So we have a couple, depending on where the pharmacist listening in today practice. But we have, for example, a community pharmacy self assessment from a couple of years ago, which we're actually updating now. And now keep in mind, these assessments are not pharmacist assessments, but pharmacy assessments about the processes where you work. But I will say, just reading through the document of our suggestions, or we're essentially asking Kim, hey, do you do this? Yes or no, or do you do it sometimes or all the time? Is the point of that? But I think just reading through and understanding where we're coming from these statements is a good starting point to learn about what is considered safe processes. Keeping in mind that there's going to be things in this assessment that are Very tough to do. And part of the reason we put them in is, ISMP has to shoot for the stars. We can't say, it's okay if you do this only level of stuff. No, we need to be at a higher level. So people understand when they read like the community one, that you must think we're nuts. Like, well, I don't have time to do that. Well, okay, but we still need to do this, needs to get done. So we have to address some of these processes associated in pharmacies. And we also have other assessments, say for hospitals. We've had hospital assessments, a high alert assessment. All these assessments are great ways to learn about unsafe and or safe practices with use of medication. So just reading, even listen, I would prefer if you use the tool in your own pharmacy. Say in the outpatient pharmacy, can get a technician involved, get the pharmacy manager or pharmacist involved, read through sections at a time and talk about those things and see what changes you can make over time. And now, in the hospital side of things, keep in mind, it's not a pharmacy assessment either. It's a hospital assessment. So you need nurses at the table. You need doctors at the table. You need information technology people at the table to discuss, to investigate the items, come back and say, yeah, you know something? I thought nursing did this all the time, but when we talk to nursing, they never do this. So that's the point of this. The assessment is the conversations that you have talking about the assessment. If that makes sense. And we also have a bunch of other guidelines from mostly acute care based, from subcutaneous insulin use, smart pump use, et cetera. The audience needs to also understand that ISMP does not come up with the stuff on our own, right? Obviously, we're driving it, but we have advisory panels who are involved in all the guidelines and assessments. So it's not just ISMP saying do this. We have 15 to 20 people as a part of a panel agreeing to the wording, modifying the wording, adding things. So it's been vetted by not just ISMP, but other healthcare practitioners involved in that process as well.
Can I tell you what my favorite thing on the website is?
Yeah, what is that?
I love lists. I just love them. You have the best lists on there. The list of confused drug names, the list
Yep.
of drugs not to be crushed. I'm trying to think of all the other ones that I've seen, but you guys have such great lists. And I think pharmacists like lists. Maybe I'm an oddball, but what do you think?
I have mixed feelings about the lists. How's that? Well, so here's the thing. A nice reference source to see what we suggest to use for tall man lettering as an example for two pair of drugs. And the confused drug name list you reference is essentially a list of reports people sent to us, but also that we wrote about and put into a newsletter of drug names that are confused. But keep in mind, like say the confused drug name list, it's not just about the name. It's about, well, it was because of the package. Where was the package stored? Are you using barcode scanning to catch these wrong drug errors? So the lists are nice reference points, but I also get concerned. I'll give you an example, Kim, the Tallman lettering list. So we have people that get that list and then apply Tallman lettering to every drug in that list. And I'm not a fan of that because it probably dilutes the effort and the reasoning for using the tall man lettering. The more you use it, the more people get used to it and say, oh. And I've heard stories where nurses have seen tall man lettering and think, is there something wrong with the printer or something? Like, what's this tall man lettering about? Well, so that list is about the rationale for using a tall man letter list. It's just as important as using tall man letters. So when a student sees a drug name, an old drug in hydrolysine, you see capital letters in it, what's that mean to somebody? It should mean, okay, hold on. This means this is confused with another drug name. So what are those two drug names? So I'm aware, like you said earlier, the awareness of the potential for the errors with those two drug name pairs. So that's why I get a little concerned with lists, because we just take them and use them. Well, no, it's got to be thought process behind that. It's not just. I guess the other problem I have, Kim, too, is listen, Joint Commission pushes for this too at times, where they expect to have these look like name lists in nursing med rooms. Well, what are they going to do with that list? What are they supposed to do with it? Are they going to stop every time they give out a med and look at the list? What are they going to do with it? So I think they're great reference tools to have. It's also a nice historical tool, the whole listing of things we've seen over the years, but be judicious how you use it. It's not meant to cause havoc with every drug name in the world, but make you aware of, hey, these 5 name pairs may be a problem. Let's do something about these 5 name pairs, not all the name pairs. Does that make sense?
That makes sense. Absolutely. I think that they bring up good discussion points. And
Yeah.
that is, I think, the value. Because, like you were just saying, a student may see it and think there's something wrong with the printer, right? Why is half of this in lowercase and half of it in uppercase? This is not right. They'll think there was something wrong or a typo. But I think that it creates a discussion point because when I was an intern, we didn't have tall man lettering,
Yeah.
and hydroxyzine and hydralazine were pretty much right next to each other.
Yep.
And just telling the intern that, hey, this is your opportunity to double check what it says on the bottle against what it says on the label, that is a practical, useful
Yeah.
discussion point. And that's all I'm talking about. Or even, I
Yeah.
think you have a list of confused abbreviations. Just knowing about those could save a life. My
Yeah.
opinion.
Yeah, no, absolutely. And I agree 100% with that. It's depends how you use the list, Kim, right? Like if you're
Sure.
using it the way you're describing it as a reference point to learn and discuss about, yes. If you're just going to do not put any thought into it and apply that list to everything you do, well, what's that solving? So you're right. It's more about the discussion, like you said, than it's about the list in itself. And one other great list too to consider is our high alert lists, high alert medication lists. So that was probably the first list Mike came out with in 1996ish. She came out with it. And so for the audience, high alert medication is a medication that is not necessarily involved in more errors. But the issue is when it is involved in an error, the chance of harm is a lot higher. So picture an overdose of an opioid or an anticoagulant or insulin or accidentally giving someone a neuromuscular blocker that paralyzes them, right? So it's important to understand the concept of that. So it's tough to get strategies put in place for every drug in the market. So maybe start with the high alert list first, because those are the ones that are going to cause the biggest problems down the road if one thing gets by. That's the other part is we degrade as healthcare practitioners regarding preventing medication errors. But it only takes one, Kim. It takes one error to all of a sudden just ruin everyone's life, including the pharmacist who has to live with that guilt the rest of their life.
Yes. Excellent examples. Those drug classes that you named. Thank you for sharing that.
Yeah. And I was trying to think if we have any other lists besides that.
The do not crush list. That
We
was a
did
good
a
one.
course list, and we've actually given that over to the publishers of hospital pharmacy. I'm drawing a blank on their name. What happened was we a guy by the name of his last name was Mitchell. I draw a blank on his first name. He actually came up with that list on his own. He did his own work to come up with that list and donated it to ISMP. Is what he did,
Wow.
and he would update it for us all the time. The only minor thing is it's a little off the road of what we focus in on. Like we're focusing on the processes of the meds that could be crushed, not so much the clinical parts of the list itself. So that's why it's still through our website, but we kind of hand that off to someone who's more clinically based to update the list. Again, it's hard to explain to people because we're not drug information people. Don't call us about what you think the best drug is to use for this condition or how to dose this drug. That's not who we are. But what were the processes with using that drug? Come talk to us. So that's a big difference in that whole take, too.
Well, we were talking about students just a little while ago, and I have a question for you about pharmacy schools. And do you happen to know how pharmacy schools use information from ISMP to inform students?
I do not know globally what's going on. We offer our newsletters for free to schools of pharmacy. The issue is over after a 20-year period is losing the contact person's name, that person moved on, who gets it now. So that's probably fallen by the wayside a little bit. I know at Temple School of Pharmacy, it's a little different. I actually teach a course at Temple Pharmacy. At the School of Pharmacy, they have a 3-course medication safety track program where you get a certificate in medication safety. So in the fall, they take a generic class of medication errors that Dr. Pat McDonald from Temple teaches based on our book. He also teaches a class about adverse drug reactions. And then in the spring, I teach risk management, which is kind of a little bit more advanced for the students because, again, we're talking healthcare processes, Kim. Pharmacy schools don't teach processes in college. They teach drugs, which is nice, but they don't teach how to use them properly and how to store them and stuff. So the spring class talks about root cause analysis, thermodynamic and effects analysis, how to identify risk of beyond air reporting, how to measure safety, and other topics. And in fact, they even get a real case ISMP done. And through the coursework of the whole semester, the classes add on to the project. So, and the homework that goes with the classes leads to a presentation at the end of the semester they give about the case. So they're teaching the class, here's the case, here's what went wrong, here's the reasons why it went wrong, here's what we put in place strategy-wise to prevent errors from happening, here's how we would measure, here's what we would measure to see if our processes have improved. So that's a part of the spring course. Now it's tough for everyone on the phone because students just know I work at Acme and I count pills and I put them in a vial and I go. So it's tough to, and listening, even for pharmacists out there listening today, do you really know all the processes where you work? Right? And so teaching that concept is kind of tough for students who aren't even exposed to any of that, except for actually working and counting pills and delivering stuff. So that makes it a challenge. But Kim, I have to be honest with you, teaching at Temple has really helped me in many ways, helped me, I shouldn't say tone things down, but speak more plainly about things. And there's nothing tougher than teaching a class of 30 students, Kim, and trying to keep them awake. Nothing tougher, man. So you got to make the classes interactive, make it relevant for them so they understand and appreciate the stories. But what other schools are doing, I couldn't tell you, but nothing that I'm aware of like we do at Temple to any degree. So they may be sharing newsletters, which is a great start to it. I think we need to have schools work with where students do rotations to determine, okay, so what hospital A, what are you going to teach our student about the processes in the pharmacy? What do you teach about the process of where drugs stored in the hospital, or the process in the outpatient pharmacy to promote or catch medication errors? I think that's something that's really missing, Kim, in teaching right now is every pharmacist graduates college, and then we learn about the processes on the job. Well, right, and every hospital is different. They all treat patients, they all do it differently. You have standardization in chains, but otherwise you're learning on the go. Like, is that the time to be learning about your processes on the first day of the job?
No, prevention is best taught early and often. Reaching college students when they're still in school, setting expectations that they need to know about ISMP and what the tools and resources they should be aware of, and the newsletters they should be subscribing to. That is important right there. I think ISMP is doing a great job through you teaching the students at Temple, but it just kind of asks the question. I know I'm putting you in a hot spot here
Yeah.
at the hot seat, but what are we going to do about it with all the other colleges of pharmacy? Preventing medication errors is important.
Yeah, and I think we need to do a better job of outreach with the schools of pharmacy. And it's tough because I've learned in the past with schools of pharmacy, they had their set classes in place. And if we're going to suggest a med safety class, well, guess what? Someone's getting the boot, right? So that starts creating issues of, oh, well, then we can't teach this class, but then it's the whole, where do we fit it in at? Well, we can make it an elective, so we'll do an elective maybe, but then everyone's not getting it. So one thing I'll add, I forgot, the Jefferson School of Pharmacy also has a medication error class for a semester I help with in the falls. So that's one semester, they're even a year earlier in college. So that's even tougher to teach them, but at least it's there. At least they're getting that background of what can go wrong. So yeah, I'm just hoping, we probably need to do better outreach as well. But on the other flip side, it would be great to have outreach from the schools of pharmacy back to us about, well, how should we be teaching people and so on. So you
That's
have
a
one way to
two-way
go.
street. Yeah, you bring up
Absolutely.
a good point. And I
Absolutely.
don't mean to belabor the topic. I just see an
Yeah.
opportunity, and I know
Yeah.
that preventing problems
Yeah.
is best addressed early and often.
Well, and one other thing, and again, I'll go back to the process issue again. In my dream pharmacy school, there'd be a class about hospitals. And in a semester course about hospitals, I'm going to learn about, well, what goes on in an ICU setting? What goes on in an OR? And the reason I'm saying that is in pharmacy school, you learned about neuromuscular blockers and you learned about anesthetics and stuff like that. What you didn't learn was the context. So what's that mean? So when I go to the OR, what do I get first? Why am I getting that first and that second? And why am I getting that third? And all the context part of it, that's what we're missing is the context. So things in a med surg floor is different than in an ICU. That's different than an emergency department. So what's the context of medication use in an emergency department as well? So that I'm thinking that still has, even if it wasn't medication safety, at least, well, here's what normally it's supposed to happen these processes in these settings.
Yes, there are a lot of different settings. That is a good point. Let's change the subject just a little bit and talk about some of ISMP's achievements. What are
Mhm.
some notable ISMP achievements?
I think the fact that we're referenced by a lot of people, I think, so is that an award? No. But when Joint Commission says, ICMP says you should do this, when we've influenced Medicare to change the 30-minute rule for surveys for hospitals, that's kind of a big deal. So I get, to me, the reward is other people citing us and saying, listen, just go to ISMP. That probably doesn't sound like a big deal, Kim. It's not like I don't have 5 trophies on the shelf to say we did this, right? But that speaks volumes. And listen, having people thank us. We try to change organizations, lives, and processes. But if I'm affecting and improving a pharmacist's life by introducing something safe and they thank me and thank ISMP for that work, that's worth more than money to me.
Well, on my own behalf, thank you for the important work you do.
Yeah, thanks, Kim. I appreciate that. And listen, we have a long way to go, everyone, and we need everyone's help on this call today. Sharing information with everybody about what goes right, what goes wrong. Also, for the pharmacists on the phone, keep something in mind. You got to know what's going on out there in healthcare world, process wise. Now, I'm talking to outside outpatient pharmacy, Kim. I'm talking again acute care, rehab hospital, psychiatric hospitals. You pharmacists need to know the medication use processes outside pharmacy. Nurses aren't taught. I mean, they're taught about medications and they're taught some stuff in nursing school, but they're not taught how to store drugs or the benefits of barcode scanning or using smart pumps. Physicians aren't taught. They're not taught anything about safe medication use. So pharmacies need to be the leader in that area. But keeping in mind is we don't have all the answers. We have to be collegial, right? And put ourselves in a nurse's shoes for the morning and do a morning med pass. Put ourselves in a prescriber's shoes and know what the challenges they got to deal with entering an order into an EHR system. See too much, Kim, of a lot of places, us against them, nursing versus pharmacy. That whole thing's got to change in healthcare. And so we're working more together. And I know some schools I think are doing that, Kim, getting the students together as med and nursing and pharmacy students, but getting outside of practice as pharmacists, we need to really step up and realize you need to own the medication use process, not just pharmacy. And I think that's one of my dream is to get that change happening.
Well, I wish you luck with that. You have a great attitude. I love how you want to cooperate and, have teamwork and partnerships. And at this present time, can you tell me about any important partnerships that ISMP already has?
One of the best partnerships we just actually developed, well, not developed, but we formalized is an agreement with ECRI. ECRI is a patient safety organization in Plymouth, Pennsylvania. They have do a lot of safety work, but it's more patient safety. They have a patient safety organization. They do a lot of work with testing devices in healthcare, infection control issues, risk management in healthcare. So we are formally affiliated with ECRI now. So it's really ECRI and ICB together going to be in one building. So I think that is pretty huge because now we have the med safety people on one side, the other patient safety people on the other side together in one building. Should make substantial difference out there. So that's probably one of the biggest ones I can think of official partnerships wise. But listen, we've partnered with associations like ASHP, APHA as an example, where we've done projects with them specifically. We should be doing more with them, honestly, and reaching out to them more. But those are, I think the ECRI relationship is a very big deal because it's now both sides can use each other's voices to really get the word out even better than we did before. So ECRI can carry our voice, we can carry ECRI's voice. And again, pharmacists want to appreciate when we say patient safety, it's stuff that pharmacists don't deal with, that infection control stuff, falls, and other complications of procedures and wrong site surgeries and all these other things that pharmacists don't know anything about, which we have enough to know now as it is, Kim. But it make people aware of patient safety is a big umbrella, and I think having two forces combined together is going to be beneficial for everybody down the road.
Definitely. Yes. One can learn from the other, and we all benefit. So that's great. Congratulations on that partnership.
Yeah, thank you.
You're welcome. Now, can you tell me, are there any myths about ISMP? And if there are, what are they?
I would say two myths. One is that we're regulatory, that we set rules and laws and stuff like that when we actually work with regulatory people. So, can we have agreements with the FDA? So, we share all of our reports with the FDA, have monthly phone calls with the FDA to go over FDA related issues of package and labeling and naming of drugs or instructions with drug use. So that's one thing. We work with CMS and commission and accrediting bodies, so we help spread the word with them. Number two, people think, well, you must have some rich government contracts. You guys must be doing great. And like, well, yeah, no, unfortunately, it doesn't work that way in the United States. It does in other parts of the world. We have an ISP Canada who's doing great in Canada because they are contracted by the government of Canada's Canada Health or Health Canada. So they have an official partnership there. Us, we rely on our publications, educational programs, consults, and donations. We're a nonprofit. So, yeah, we need the help of everyone, obviously, as a business, because we want to help you, but we also need the help and contracting of people, too, to get the word out, even if it's by donations. But we don't have these exorbitant government contracts that are paving the way for us in that manner. So that I think is the one big thing too. I think people think, oh, well, you guys must be rolling in the money for all the work that you do. And what happens is a lot of times, Kim, our guidelines or self-assessments, we get grants to do those, which is great. So we get a grant to do a self-assessment. What that means for the listeners here is you get the stuff for free from ISMP, right? That may not always, but keep in mind, but we may not always get that grant money to put out IV push guidelines and compounding guidelines, right? So that's one piece of the puzzle, but we do a lot of things, and we also do a lot of free work. The work when we go to FDA meetings, that's free. If I'm traveling to USP for a meeting, that's free for them, and I pay the expenses. So a lot of these advocacy things, and also with consumers, right? We have a consumer reporting program, so we have consumers report stuff to ISMP, and Kim, I'll tell you, it's a different animal. A lot of consumers most consumers are reporting because they think someone's gonna get in trouble. Because inevitably, Kim, it's funny. Oftentimes, the people in my mind, the consumers report not because of the error, but because of the response to the error, and they feel like the pharmacist blew them off, ignored them, poo-pooed them. That's when they get mad and they report to us. It's really interesting, but you can tell by the wording how things are done. But I will say we have learned a lot from consumers. It's one for everyone in the audience. Please, if you can change one thing in the outpatient setting. If I hear you get one more report about a patient who got a medication, they went home, started taking it, then they read the label and say, "Oh, gee, this isn't my prescription. What the heck's going on with that pharmacy?" For crying out loud. Well, okay. First off, someone's in the store. They can get a white bag in their hand. Open it there. Would you rather find out what was wrong there or when they get home later?
At the pharmacy.
Right. So encourage them. Open a bag. Are these all for you? Look in the bottle. Is this what you're expecting? So they say, "Oh, is this a different generic?" You could say, "Oh crap, no, that's not a different generic. We got the wrong thing," or "It was a different generic." It just drives me nuts when people, and listen, we also have to educate consumers to step up to the plate. Okay. Unfortunately, consumers tend to treat outpatient pharmacies like McDonald's, except for one big difference, Kim. They went to McDonald's and they ordered a Big Mac without pickles. Would they look in the bag before they left to make sure the Big Mac didn't have pickles on it? Well, you actually, I say they do. They do look at the Big Mac to make sure that it was made properly. But in the pharmacy, they don't do the same thing. So that whole, we have to partner with consumers. It's a two-way street. We have to encourage safe practices, but we also need a little pushback from them too to make sure at least at that cash register when dispensing, Kim, that make sure that there's that interaction and checking things before they leave.
Oh, you bring up a good point. Yeah, it's not all just on the pharmacist.
Yeah.
Well, it sounds like for a nonprofit organization, funding is a challenge, and you wouldn't be the first one to say that. But can you tell me about any other challenges that ISMP faces?
I wouldn't say, ISMP as an organization, it's the same, especially with COVID, Kim. Passion, listen, for everybody, COVID threw everybody off, right? And everyone's
Yep.
resources and time and effort went to COVID, and it's still happening today. So that's something we all have to adjust to. I think the challenge is, in my opinion, is getting permanent change in healthcare, right? So we'll do a consult at a hospital, find tons of stuff that's wrong in this one hospital. Will they change everything? Who knows? And that's one hospital. That's not 1,000 hospitals. It's not 3,000. And same for outpatient pharmacies. So I think our challenge is, in my mind, getting standardized changes across the board. So we're doing certain safe practices uniformly. For example, State Board of Pharmacies, they do these inspections at retail pharmacies. Are they inspecting the processes in there? Are they inspecting what references you have and where's your license hanging on the wall and stuff that doesn't do anything for patient safety? So I think getting everyone on board to standardize things as much as we can, share our learnings. And it's a challenge for us because we can get one hospital to change. We can get, or even a lot of hospitals to change based on what we wrote in a newsletter, but it's not all of them, right? And so it's not all of them. Then we already having breakdowns occurring. And again, if there's going to be disparity in healthcare and processes, it's going to lead to an error.
That does sound like a challenge. You have only so much influence for everyone that you have helped. There are more out there that need help. There's
Yeah.
only so much of you to go around.
Yeah.
As this is a podcast that is listened to by pharmacists, can you tell me how can pharmacists and pharmacy students, maybe even pharmacy technicians, get the most out of ISMP?
I go back to what you said earlier, Kim. Take a look at our site regarding our tool specifically. Our newsletter subscriptions aren't that expensive especially the outpatient pharmacy. So consider getting up-to-date information from our newsletters. But the self-assessment tools, I think, are really great ways to learn about all the things that should be done right. Second, share your stories and concerns with us. Not just, we get a lot of lookalike packaging reports into ISMP. That's nice. Well, how about breakdowns into processes? Like, what are your concerns of where you work? And tie us those stories because those stories can lead to change. We have had changes in product labeling, product names. We had changes in standards at Joint Commission, and that starts because people tell us. We only know as much as you tell us. But again, not just Kim gave the wrong drug. The whole thing. Tell me the whole story around that. What contributed to that? Especially in outpatient pharmacy when you're probably short-staffed, people are staring at you, getting prescriptions done, phones are ringing off the hook, the bench is crowded with drugs you couldn't clear because you're so busy. We need all that. That now all of a sudden changed the story, Kim, because now I gave you I described the environment. So you got to share that and share our resources too around the world.
Well, thank you for that. Now, as we wrap this up, is there anything else you'd like to share?
No, I was just encouraging pharmacists on the call to always be on the lookout, always try to improve your learning about medication errors and why they happen, right? And a lot of people have continuing education requirements, but my state in Pennsylvania is maybe 3 hours every 2 years or whatever it is, 4 hours every 2 years. That's not going to do the job. So how are you keeping abreast of not just ISMP, but other learnings about medication safety? Because ISMP can't do it by itself. And we need your help in not just reporting, but insisting on changes. And sometimes that means speaking up louder and also higher up the chain of command too, right? At times it seems like we're all these staff pharmacists working together to prevent errors, but we have to get the pharmacy leaders need to open up too and want to make change and simply ask their staff, what's going wrong today? How are you feeling today? What concerns you about working here, Kim? One of the best questions you can ask a staff member, especially in a hospital setting, we always ask this on consult. You walk up to a person, Kim, and you say, Kim, when you go home today from work, what's the one thing that really concerns you that may kill someone tomorrow at this hospital? And answer that question. And I will tell you, I've done it in person, and I've had nurses tell me stuff with the nurse manager standing next to them. Nurse manager's jaw drops to the floor like, no one ever told me that. Well, you didn't ask. Ask your staff. Ask them about what concerns them about safe medication practices. I think that's a huge starting point, just simply asking.
Yes, and by asking, you show them that you care about it.
Yeah, right. Absolutely.
Well, thank you so much for sharing your wisdom and sharing about ISMP today on the Pharmacist Voice podcast. I hope you have a great rest of your summer, and I hope to talk to you again sometime.
And Kim, thank you for this opportunity, and I hope we do talk again in the future.
Thanks again to Matt Grissinger for being my guest on the podcast today. He really is a wealth of information on medication safety. Visit ismp.org today to see the tools and resources he mentioned. The self-assessment tools are easy to locate on the website, in my opinion, and the lists we mentioned are there as well. Again, visit ismp.org and explore the tools and resources today. I want to thank you again for listening to episode 107 of the Pharmacist Voice podcast. Please visit thepharmacistvoice.com to read the show notes. You'll find links to ISMP, ECRI, Temple University School of Pharmacy, and other details mentioned in this episode. And if you liked this episode, share it with a friend, and be sure to subscribe or follow this podcast. After you subscribe or follow this podcast, it will be delivered for free to your favorite podcast player every time a new episode comes out. Thank you again for listening.